the topic that we have for today, it's kind of a mouthful, genomics and the diagnosis of childhood brain tumors. And what I was hoping we could do, just instead of going through every nitty-gritty piece of technical detail about genomics, is to maybe bring into focus a little bit what you would see in the news, what you'd see in lay print, lay media when we say genomics, because it is a fairly large topic, but something we're very enthusiastic about. And I would just start with one slide, just one basics about what this room really knows a lot about, just the current diagnostic paradigm, because it really hasn't changed much, right, in 2 decades or so. This is actually one of my patients. On the screen to the left, you can see there's imaging. When we diagnose patients, it's done by our frontline physicians and our families that really recognize that something is going on, something is wrong. And with imaging, plus minus some lab markers, depending on the diagnosis, a surgeon does a lot of work initiating the treatment. And then, even though the microscope, we see a lot of detail, we are looking at things from afar. And what we'd like to do with our next step is, what's the genomic and sequencing potential? And for the purposes of this talk, when I say sequencing or genomics or molecular classification, they're interchangeable terms, and I'd like to focus on this little square today. Is when a child goes from surgery, in the box it represents, that's just a particular tumor type. It's known as medulloblastoma, but we would like to get to what's, quote unquote molecular classification. And this becomes the basis for precision care or precision oncology, and it's not a new concept for us, right? For leukemia, we've been doing this for ages, depending on the age or some laboratory findings, some genetic findings. We can individualize how we treat these children, but in pediatric brain tumors, we just haven't quite gotten there. And maybe we can get there if we start looking at the genes. Now, this is a busy slide, but I would like to focus on, there's this large red arrow that points to today. And if you look at, I'm not sure if I can get it quite over there, but right around that box is a decade and a half of the Human Genome Project. A project that took that long and cost $4 billion some odd dollars. They were able to sequence, and when I say sequence, they were able to take all the letters, that one big line that make up the human DNA, the blueprint and construct of what makes us tick and what makes our cells tick, the programming, and figure it out one by one. And now we're able to do this by splicing up all these little sequences, doing it together. In a span of weeks to months, we can get that DNA as well. And so that really takes us, because of the state-of-the-art technologies, we're able to now go from one letter at a time for DNA to a whole bunch at a time. And it's really just because of, in the last 2 to 5 years, particularly in pediatric brain tumors, the technology is able to give us information that now us as clinicians, we're trying to figure out how to make that advanced care for our kids. And the basis for this is, we've known for a long time that cancer is a quote-unquote genomic disease. The image on the left is a graphic representation of what we refer to when we see a molecular classification. There's a lot of rows that just represent the chromosomes. A lot of different tumors are put on top of that. See, the little red hills just represent changes in different genes and what we'll refer to as mutations. And these large hills of a few of them that recurrently, they just over and over again start to change. And it seems like it's somewhat of a overwhelming process when we think of 20-some-odd thousand genes in our human DNA, our blueprint. But the fact is, we're somewhat lucky in the sense that there's a small number of core pathways, and if you look at each of these little letters, like 4-letter, 3-letter names, they all represent genes that can be dysregulated or just altered, put out of whack in that pathway. And if we can put the brakes on those pathways, then we have the basis of giving all of us a better diagnosis, and so that we can treat it better. And so that's our main clinical diagnostic application, is if we can have better information, we can better inform our patients and our physicians, and in turn, give us better treatment. Fact of the matter is, we are at the tip of the iceberg, and there's an incredible number of challenges and limitations. And 2 to 5 years seems like a long time, but the fact is, we're limited by the amount of the preclinical models that we can use to test new medicines. We're limited even by the number of medicines compared to our adult colleagues, and we just don't have a lot of experience doing this sort of technology. all of the information we've been getting, a lot of it is purely in the research arena. And for us to do it in a clinical setting, it requires us to be more creative than we've been before, innovative clinical trial design. And so just to give you a couple of examples of what's been going on, one of the great blessings for me finishing training in Texas Children's is that I've had mentors that are, one, in the top of their fields, and two, doing very innovative and very important work. This is a study that they're currently running. It's ongoing, and the early experience is just in press, but it's colloquially known as Basic 3 over in Houston. And the goal here, it's a busy slide, but the main points are, when we see patients, that's the first box, and we do our traditional care, we're able to take samples of tumor and samples of blood in a clinically legitimate lab, take those results, do all the sequencing, have all those lines of letters that represent the DNA blueprint, and that goes into the medical records. And that's going to greatly inform how we deliver this information to families and how we use that information as physicians and oncologists. There are, for sure, whenever we speak of anything that's related to genomics, that Gattaca movie, that fear of genetic information starts to come up. And our experience so far is that of over 200 patients, the vast majority of families are very interested in getting this done. And if I can draw your attention to that small light blue box, the genetic anxiety, it's a very small percentage of our families that have hesitation or would rather not get the sequencing done because of gene-related concerns. And indeed, we go back to that same graphic representation, but all these little letters here, these are different genes. They're just names that researchers have come up with that are very important in pushing a cancer cell forward or giving it some sort of advantage so that it can become a cancer cell. And what we know, and it's consistent with what's already known in the literature, is that there's some genes that are very important, but this big box on the bottom in red, very important genes are only mutated or changed in specific numbers of tumors, meaning we may only have one tumor out of 200 plus that we sequenced that have that gene. And it really tells us then that one-size-fits-all formula just doesn't really apply. You know, pediatric cancers are, as we know, different than adult cancers. And if I may, I'd like to go through a few examples, both in our experience and in the literature, of how this is already starting to change our perceptions of how we our day-to-day when we take care of children's brain cancer. This is one of our patients, a 9-year-old boy with PAA. I just left out his PAA because the name of that tumor is somewhat confusing in itself. It's called a pilocytic astrocytoma with anaplasia. And I'm certain there's several in the room here who are very familiar with the concept of a pilocytic astrocytoma. I'm certain there's others in this room who are familiar with the term anaplasia because we have, in one sense, a pilocytic astrocytoma, a benign, slow-growing sounding name, a slow-growing entity, mixed up with the term anaplasia, which just sounds high-grade. And so now we have a tumor name that combines both. And what the genetics and genomics is able to tell us, on the top, that's the MRI. On the slides, that's our view from afar, microscope slide. And on the bottom, I wouldn't go into the technical parts of this, but again, it's just a graphic representation of when we take 3 billion or so of these letters, also known as bases, if there's one tiny tweak in an important gene that's altered, the technology can now detect it, and indeed, the literature points, if you can look at the figure on the bottom left, that little red circle correlates pretty nicely to where the circle is on the MRI, and this mutation, also known as H3F3A, tells us a little bit about the high-grade nature of this type of tumor, even though it's something that we're just learning about on a microscope. Another example, this is one of the most well-known examples in pediatric care because the researchers and the clinicians that work on medulloblastoma have certainly pushed this concept further than any other tumor type. And this is a 16-year-old. On the top, again, the MRI microscope slides, and on the bottom, a bunch of mutations that were discovered on the sequencing technology. And what it does is we can now give a better diagnosis. Instead of a 16-year-old child with medulloblastoma, we can give core subgroups. So medulloblastoma either with what's colloquially known as a Wnt type or sonic hedgehog type, or what's currently just known as group C and group D. For sure researchers are going to identify more subtypes, but we definitely can now stratify what sort of treatment a child gets. This is just one trial that's already doing that. What sort of treatment a child gets because the diagnosis is more precise and the treatment's going to be more precise. Now, this is a well-known example in the literature for which a very famous mutation known as BRAF V600E. On the top, all these waves again here, just a graphic representation of the sequencing information. And this mutation is made very famous because of the adult trials in patients with malignant melanoma, because they were able to use a targeted medicine called vemurafenib, and I think you'll hear more about that later today. But from one slide to the next, where that arrow is, that lesion on the MRI starts to disappear, an area that surgeons can't get to very cleanly or very safely. And what I think a lot of us are excited about is the potential to stop these core pathways in its tracks. And that's what we got to learn more about, because for the most part, it's probably going to take a lot more than one medicine or two medicines, and that's what we're working through. So ultimately, this is just one quick slide that Dr. Parsons is the national principal investigator through the Children's Oncology Group, is otherwise known as the Pediatric MATCH study. And I think it's an extremely important slide for our purposes because PBTF is a main supporter of Project Every Child through Children's Oncology Group. And just as a section of what that is, the main points of this slide is a child will come into us, and this is a child for children who have tumors that returned. The tumor can be sequenced, and we can find genetic and molecular information about it. And the goal ultimately would be to try to match changes that are important in that DNA, so in the blueprint of a tumor's DNA, with a medicine specifically designed to target and slow down that change. And so that's something that Dr. Parsons has been working on for the last year and a half or two, which hopefully will be in the works over the next couple of years as well. And so I just want to conclude with one more concept, is just that broader diagnostic implications, because we're talking about DNA, the DNA of a tumor and the DNA of a person, the normal DNA. And this is a 14-year-old with GBM, it's just a tumor type called glioblastoma. And the shaded circle represents her, and this is the family tree. The box and the circle above are her parents, and her siblings are the two boxes that are on the same row as she. And our current practice is just to ask. We ask families, is there a family history of cancer? There is. This is how we document it. And if it rings a bell, we should look at targeted potential causes of predisposition syndromes or changes in normal DNA that might make it more likely for a child to get a tumor. And we're cheating a little bit because this was a child enrolled on that basic 3 study, and there's sequencing results from her own DNA that we already had. But going back and in retrospect, we can see her on the maternal side of her grandparents, that family history looks a lot less benign. And indeed, when we go through all of the colors represent an extended family tree and a family members that was affected by cancer. And our sequencing results demonstrated a change in her DNA. In this particular case, it's MSH2. And it has tremendous implications on screening for her family members, and of course, any further generation as our children go on to have kids of their own. And so, I'd like to wrap up. This was the patient I first brought up. In fact, she was one of my first patients I've ever had. And this was the first slide, our current diagnostic paradigm, right? Imaging, surgery, and then the microscope slide. And this was her tumor sequencing results. We found a few things that, if we need to, and the tumor comes back, conceivably we could try to target PIK3CA, just the name of the mutation, and the other one's FGFR1. The main point is, if we need to find some sort of medicine in the future, whether near future, intermediate future, or far or extended, we could start looking for clinical trials or medicines that can target it. And the next step was, her clinical findings was very consistent with a genetic syndrome known as Noonan syndrome. And when we sequenced her normal DNA, that's what we used to compare the tumor DNA. Indeed, there was a very well-known change called PTPN11, which was consistent with this genetic diagnosis of Noonan syndrome. And so, while she was already getting a lot of care for other medical comorbidities, it nicely put together the genetic and clinical presentations in a nice comprehensive genomic diagnosis. And so, this is just one sense of how this sort of information is already starting to crawl deeper into the iceberg and give us information that we'd never had before. So ultimately, I'd like to conclude with that, but I'd be remiss if we didn't thank our families and patients. And everyone in this room really makes my day-to-day back in Houston just a tremendous blessing that I just, I still have to pitch myself that I get to do this. And this sort of work with genomics is extremely subspecialized. And this is the neuro-oncology program at Texas Children's. And the individuals who go into doing sequencing-related work, my role as a clinical neuro-oncologist with a particular interest and focus in clinical genomics only happens because of the very specific technical expertise that can happen. And these are the individuals who can do all that. So that's it. Thank you.
I'm Shannon Raber. I'm an acute care nurse practitioner at University of California, San Francisco. And I'm involved in the, I'm the outpatient nurse practitioner in our pediatric brain center. Dr. Sabina Mueller is with me also. She's the director of our pediatric brain tumor program, and she'll be speaking shortly after me. I'm actually talking about a topic that I think most of you are experts at, or hopefully you benefited from this type of care, but I think we're pushing this more into our programs all around the country because this is how we should deliver care, the comprehensive care model, and then Dr. Mueller will talk about how that comes into new therapeutic approaches, taking off on what Dr. Lin was talking about, the genomics. So we'll talk about what, why, and who is involved in comprehensive care, how the team differs at various time points, and then the important qualities of these care providers. So what is this? Comprehensive care is an approach that cares for the whole patient and all of his or her needs. You all know how important that is, and it's not just the medical care, it's not just the tumor-directed care. That's very important initially to get that all finalized, but there are a lot of other needs in the family and the patient. So using all these services of many different professionals. So the American Cancer Society has a statement on that. Some of our leading groups also guide us in this way. So in 2009, the European Pediatric Oncology Group came out with this statement that providing this kind of comprehensive care helps the patient make a good recovery and ensures optimum quality of life. It's so important. And then the American Academy of Pediatrics also put out in 2004 that the clinical results in children with cancer have been their outcomes have been shown to be superior when specialized care is delivered this way, in this comprehensive manner. So this has been going on a long time. We've been talking about this a long time, but I think we're getting better and better at it. You'll meet many of these players along the way today in the different talks, and I'm looking forward to also our colleagues that help deliver this. So this is a slide, it's you all know this, it's a long road. We hope that it goes from diagnosis when we meet you, we know you never wanted to meet us, but that it's going to go from diagnosis, we'll get you through therapy, and on to survivorship. Unfortunately, we know sometimes recurrence can happen along the way, and sadly, for some people, it ends with the loss of their child. But we hope to keep you on that road to survivorship. It may look like this, but in reality, we know, and you know now, it looks more like this picture where there's peaks, there's valleys. We could talk about all the different analogies, but wrong turns, straightaways, uphill battles, it's not a straight road. So who's going to be on this road with you? Who's going to be on your team? The box in the red at diagnosis, you meet all these people. And as you probably know, neuro-oncology can mean fellow, attending, resident. So it might have multiple people within there. Neurosurgery is critical, radiation oncology right up front. Child life, we need child life there for the kids. Social work, fertility specialists, we're making much progress in introducing this right away, what can be done. And then palliative care needs to be there too. We're getting better and better at this, but that needs to be in the conversation. This should be happening at a tertiary care center where we can provide all these services. We have all these people there. Second opinions are critical. We help facilitate that. We encourage that, reaching out to our colleagues. Sometimes it's provider base. Sometimes the families will go. Are you going to participate in a clinical trial? These are the people sort of in the gray box in the background. They may not be in and out of your room, but they're also following along. They're on your journey, just maybe not necessarily right in the visit or in your hospital room. Just a little pearls. At this point, don't start therapy until all of your questions are answered and you're well informed, and letting others help you along this way, especially friends and family. Specialty tumor boards happen at various time points. We meet weekly. Various institutions do this, where all of these players get in a room, hear the story, look at the pictures that, like Dr. Lynn showed, the MRI, the pathology slides, and now we video in with our molecular tumor board, so then we're hearing about the sequencing results. And then everyone together is making decisions about treatment, about changes, following along. So often this is the way second opinions come out, but it's a critical platform for the team to meet together and provide this, what are the goals of care? What are the barriers to some of these things we can do? Then on your journey through therapy, there are a lot more people you've met, whether it's your favorite local phlebotomist or the nutritionist that we need up front to help us with the picky eater that now is going to be nauseated. Your school, the community. Your community involves many people, family, and still more people in the background. Do we need to refer out for dermatology assessment, cardiology? So there can be a lot of people along this way. Siblings, though, despite all this need, this is an important time for siblings to have support as well, because it really does take a village. Going on to recurrence, it may pare back down to the neuro-oncologists, to the radiation oncologists, the nurses. Now are the clinical trials phase 1 or phase 2? More decisions need to be made, second opinions. Do you need to rebiopsy so we can get more tissue for more genomic analysis? The players are still the same, but just shifting who's more in the forefront. Goals of care discussions are critical. We always want cure, but now are the goals of care shifting at all? Do we want to make sure that the young adult can still stay in college? Can we provide the services locally? Trying to be creative with how we deliver this care. Community and family are very important all along the way. And then from tumor-directed therapy to focus on comfort if things are changing and we're looking at the end of life. I told Dr. Mueller this slide always, it's gonna make me cry, but palliative care, that's why it needs to be there in the beginning, so these aren't brand new faces necessarily. Family and siblings, we need to remember. Neuro-oncologists still staying involved, nurses involved. Now your primary care may be back involved also. The community's always been there. Other specialists may be consulting, teachers, school, keeping everybody involved. We need to access any and all resources for support at this point. This is not the time for people to fall off your team. Always having hope. Sometimes the hope is changing. The hope was for the future. Now the hope is that tomorrow's a better day. Survivorship. We'll hear a lot more about this today, but there are maybe some new players on your team now, the late effect specialists. They were always probably there in the background guiding us on upfront therapy, but now they are more in the forefront for you. Different specialists that we were maybe consulting briefly are now helping provide more care, like endocrinology, nutrition. Multidisciplinary clinics are a great way to deliver this type of care, especially at this point. Continuing to advocate for your child, but now maybe even more so, school, navigating that system, adjusting to the new normal, dealing with the post-traumatic stress that we caused. Sibling health and parent health, very critical. Now's the time to take care of yourself. Now the siblings need to be back involved. And little shout out to siblings. I'm a sibling of a pediatric cancer survivor, so the siblings are going to be okay, but we need to pay attention, get them involved. This is our multidisciplinary clinic at UCSF. Well, it's not everyone, because these are very hard people to get in one room, to sit down, look at the camera. They don't follow my directions. But so at one point, they're all in the room. the ophthalmologists, we're doing the follow-ups, the endocrine, AYA specialists, neurosurgeons, neuroradiology. Everybody is either in the room or we're calling them. But what's important to come out of this room is communication to the families, communication to the patient, communication to the primary care provider. If you're traveling 3 hours, you're not always going to see us, but we need to make sure someone local knows the care that you need, that the patients need, and sharing that information, whether it's in our notes or a summary for the families. Sharing amongst ourselves. We're learning from each other all the time in these multidisciplinary clinics. It's great for us and for patients. And the survivorship passport is, different institutions have different forms of this, but it's a summary of the treatment. How much radiation did you receive, where's the tumor, and then we follow the guidelines from the survivorshipguidelines.org from COG, pairing that with exactly what the treatment was. So I think you are all experts on most of this, but this is very important to us as providers to kind of provide this care in this manner. And the qualities of this team, you probably have other descriptors, but when we think about it, it's, hope, trust, advocates, providers, guidance, expertise, but probably most critical, good communication. There are a lot of people we need to keep together, and it can't be just on the families, it's on us too to do that. So, but this is the best way to provide care, and this is why we need to provide care to our kids with cancer. So now, moving on, it's Dr. Mueller.
So good morning, everybody. I'm Dr. Müller. I'm the director of a pediatric brain tumor program at UCSF, and I'm also leading, together with Dr. Michael Prados, consortium, which we refer to as PNOC. It's the Pacific Pediatric Neuro-Oncology Consortium, which consists of 15-member institutions. And some of the new therapeutic approaches I show you today is conducted through PNOC. We are often invited, obviously, to present at these scientific meetings. And I told my husband, this is being here today and being able to present to you, it's a huge honor. It's so important. We are in this together. We have to be a team to really make a difference for our children. So I wanted to thank you, all of you for being here today. So we heard earlier this morning from Dr. Lin, there has been really an explosion of data in terms of this genomic area. And I feel like in pediatric brain tumor world, we are still a little bit behind in trying to translate all of these great findings into new clinical approaches for our children. As we heard earlier, just briefly, we now know that even if we call it the same tumor type, such as medulloblastoma, we know that the tumors looking the same under the microscope, we call it the same. They're different when they present in an infant versus a child versus an adult, and each of them have different subtypes. We also know that these different subtypes result in different outcomes with our current treatment strategy. And right now, we are still treating most of these children as this was one disease, but it's really not. And so we realize, for example, that, children who have this blue type tumor, which we call Wnt-driven tumors, they have excellent outcome on our current treatment strategy. And these children, for example, are being treated with surgery, whole brain and spine radiation, followed by chemotherapy. And some of you might be familiar with that. But we realized there might be a subgroup of children who need less therapy, and so then they have a long-term better outcome because they're not suffering from a lot of toxicities. And maybe for other groups, we need actually different ways to treat these children. But we are just, and this data we now know for many, many years, we're in the early, 2002, the first papers came out, but we are still just starting to translate this into the clinic. So it takes a huge amount of work and effort to really put this then into the clinical care for our children. And the same is true for glioma types. We know now, even if we call it one disease, there are many different, and we need to really be able to use that information to deliver the best care. So one of the trials we evoked on within PNOC is a pilot trial testing how we can really bring this to our patients. A lot of what we heard earlier this morning and what is being done through the MATCH study is really trying to take the tissue from a patient, applying sort of this next generation sequencing, advanced technology in the laboratory, collaborating with these genomic experts, and then really trying to bring it back to the patient. And what this study does is basically we take the biopsy, in this study we collaborate with the Translational Genomics Research Institute in Arizona, apply this genomic these genomic technologies which are now available to us, and then we identify the mutation in each child's tumors, and then we match this with up to 4 FDA-approved drugs for these children. Because as was also mentioned earlier, we don't believe that for most of the tumors, one drug will be sort of the results in leading to a cure. We think that we need combination therapies. And so this is something we started. We have been able to show now on 13 patients that we can do this, that we can do this in a clear sort of clinical approved setting, and that we can achieve this in a really good turnaround time in a multi-institutional setting. And that is something which I think will help us to design the next future studies, that we can really bring this precision medicine approach forward to our children. And this is sort of a lot of fancy technology which goes into this, but we are just starting to explore this really for clinical use. So I think there will be much more to come in the next few years. But one of the big issues we are facing in pediatric neuro-oncology is, I'm sure you all heard the term blood-brain barrier. And what the problem is, specifically in our field, so even if we find the mutation, even if we have a drug which we can match, and we know from laboratory data that this drug is really effective against this mutation, we don't know if we give the drug to a child either by mouth or through the vein, what we are currently doing, does it even reach the tumor, because there is this blood-brain barrier which limits that a lot of the drug we are giving our children is getting even to the brain. And so we were able to cure many, many brain tumor types in the preclinical setting in our animal models, but then when we tried to translate this to children, often the results were pretty disappointing. And I think many of us believe that this really because the drug is not even reaching the target. And so one of the areas which I think you will hear a lot about in the future is something which we call convection-enhanced delivery. And what that is basically direct delivery of the therapeutics into the brain by placing catheters directly around or in the brain tumor to bring the therapy right there. And that will do two things. First of all, we will know that the drug is getting there. And second, it will alleviate a lot of the systemic side effects our children have to experience, like the nausea, the vomiting, the rash. So we are hoping with this directed delivery that we can make really a big step forward in sort of the therapies for children with brain tumors. And just to show you some examples, I mean, this is something, and this development is years of development, developing in with collaborations with our neurosurgeon, these catheters where a little borehole is made into the skull, you place the catheter in it, and then basically give medication through it. And then you can basically, under image guidance, and I show you a little video to make this more clear, then you can adjust, while you're injecting the medication, you can adjust these catheters to make sure it really ends directly where the tumor is. And this is a really exciting area where now companies are starting to develop these systems where these catheters are placed permanently under the skull into the brain tumor area with up to 4 catheters. And then there's a little port, and I'm sure many of you are familiar with the port where we can give repeated medication into the veins. And the idea is that we can do something very similar, delivering the medication directly through a port, and this is shown here from one of the examples, through a port, many times, repeated times, directly to the tumor. How great would it be if we could offer this to our patients? You place this, instead of giving it through a port into the vein, you give it directly where the tumor is, with the hope that we don't see a lot of these systemic side effects we are used to all seeing. And so But also, you need to package the medication in a way that you can deliver it in this. And so one of the other areas which I think will be extremely helpful for us in pediatric neuro-oncology is sort of the collaboration with nanotechnology. And what nanotechnology is basically trying to package medications in a way that you either can do it in combination or you can prolong the half-life, because obviously you don't want to have to place a catheter every week in a child's brain. You want to maybe do it once every 2 months or maybe even every 3 months and have a medication stick around in the tumor for a very long time. And so one of the ways to do is to package the medication into what we call sort of liposomes, and we have shown now in preclinical models and also in non-human primate models that then if it's packaged in this lipid surrounding, then the medication sticks around for a very, very long time within the tumor tissue and continues to have effect. What this technology also allows is that you package multiple agents in these liposomes, making it easy for combined multi-drug therapy, and also to make it easy so that you can put it with, for example, gadolinium. Most of you are very familiar. This is the dye you're giving when children have an MRI. So you can directly monitor under imaging where the drug is actually going. And so, you know, when we bring new therapies to our children, we first study it in small animals. These are rat brains, and you basically see that if we package these liposomes with sort of a fluorescence dye, we can actually then see it in the brain of these mice. And then we collaborated in a larger animal model. These are dogs at the university at Davis. They developed spontaneous brain tumors, and so it's a large animal, and there we did a lot of studying, refining the catheter placement and everything, and then these dogs get injection with these catheters, and again we see nice tumor shrinkage. And now this finally has been translated into the care of humans, and so this is a patient with adult high-grade glioma, and what you can see here, what you can see here on the catheter goes in here, and then there's a little video playing where the white dye is basically, you can watch it directly under imaging guidance, and you can directly see that the dye with the medication together is going directly where the tumor is, and you can adjust the catheter in a way that you can directly visualize it. And so I think this type of technology is really important to advance the field and bring better therapeutic options to our families. And what I just summarized, you know, like 3 or 4 slides, I mean, this has been work which is going on for like 20 years. Many, many different laboratory works on this. This takes a lot of refinement in the catheters, in the mounting systems. We collaborate with neurosurgeons, we collaborate with companies making these little catheters. And then obviously we are also collaborating with biotechnology companies making these medications in a form which stick around longer. But I think this will be a very exciting area for us. And we are planning currently a trial using this for children with diffuse pontine glioma within PNOC. There's a trial open at the Memorial Sloan Kettering Hospital using that technology of convection-enhanced delivery, using a radio-labeled antibody. And then in Europe, they're using that implantable system I showed you to deliver other agents for children with diffuse pontine glioma. So the other thing I wanted to highlight, many of you might have heard about the sort of new era of using oncolytic viruses for the treatment of children with brain tumors that had been put forward for adult brain tumor patients. But here's, for example, one model. This has been done at the Mayo Clinic by Dr. Raffel. He used a modified measles virus. All of you know what measles virus is, but this virus has been modified in a way that it's not causing the measles, but basically we have shown in the laboratory that it basically attacks cancer cells, and in this case this was a model of medulloblastoma. And you can see here that mice treated with the virus, really the tumor basically disappears, whereas the control mice, the tumor continues to grow. And so this is data then which brought this whole therapy area of oncolytic measles virus forward, and the Mayo group has used this in adult patients with multiple myeloma, and the virus is given through the vein, and they've seen amazing responses in few patients. So this is a very exciting area because it's very well tolerated, none of the classic chemotherapy side effects. And it had also been given to adult patients with ovarian cancer directly into the abdomen, and it has been shown to be really safe, very limited side effects, and some really encouraging responses. And so the Mayo Clinic is currently conducting a trial in adult patients with brain tumors, and what we are planning to do, based on our preclinical data, on safety data in non-human primate, like in monkeys and everything, which has been shown that this is a really safe method, in children who have localized recurrence, and this is often where we first test these novel therapies. We don't often put it up front, we test it at the time of recurrence, and this is what Shannon was referring. We use then the phase 1, phase 2 enrollment. By the time the tumor has come back, unfortunately, often children undergo resection of this tumor now, first of all, to learn more about the tumor, and at the time of resection, then the virus will be put directly into the resection cavity. If a child has evidence that the tumor came back not just as one location, but in multiple locations, then what we call disseminated disease in the spine, then we would give that virus through a lumbar puncture. And this has been submitted to the FDA, and so we will see what they think about our proposal, but we had many conversations with them, so I think that will become available soon. And then there are already ongoing trials using these oncolytic viruses. Like I mentioned, the Mayo Clinic is currently doing this for adult trials, and then they have a Rio virus with some chemotherapy options also as a phase 1 trial. So I think that's definitely a space to watch, and I'm hoping that for some of the tumors, this will be really exciting results in the recurrent setting so that we can move it up front, because again, that would mean a lot for our patients in terms of side effect and long-term morbidity of our therapies. The other big topic, and this could fill a 2-day symposium, is sort of this new development of immunotherapy. I mean, this is sort of an area where we're all excited about. It made huge press for, our patients with melanoma, for leukemia. We, in brain tumor world, we are still not quite sure how this will work. But just to give you an overview, if you think about immunotherapy, there's the monoclonal antibodies which are designed to attack a specific molecule of the cancer cells. Then lately, really, the immune checkpoint inhibitors, and these drugs basically take the brakes of your immune system, which helps it recognize the cancer cells and basically attack them. And the Pediatric Brain Tumor Consortium, the PBTC, has, I think, one trial opened testing one of these in children with brain tumors just to find sort of the safety data. And then there's this whole area of cancer vaccines, and the cancer vaccines come in all different flavors. It could be that there's a specific peptide they use because they found that on the tumor cells there's a specific molecule which is very present, and then you just use that. Or you take the whole tumor from a patient, which ultimately you can see that the ultimate precision medicine approach, and then basically try to incubate your immune system with the tumor cells, prime it against specifically the tumor cells, so then that your immune system basically attacks the cancer cells specifically. And so what will be put forward is sort of a dendritic cell vaccine approach for children with brain tumors, where dendritic cells are the antigen-presenting cells, and they are key in sort of eliciting an immune response. And then the idea is that you take from each child through leukapheresis, some of you might be familiar with that, you take the blood out of the child, you collect from the blood these dendritic antigen-presenting cells, and then in the laboratory, you incubate these cells with either the whole tumor lysate or part of the tumor to prime these cells against the tumor cells, and then basically you bring it back to the patient as vaccines by giving a shot to these patients every 3 weeks in clinic. And so there's some really encouraging data in adult brain tumors, and we are just starting then to develop this for children as well. So this is another really hot area we are trying to move forward for our patients. And then importantly, the challenge for us often, and I know you've all been there, is the imaging definition, what we consider is response, not response. I'm sure many of you have been in the situation where your doctor tells you, oh, we are not totally sure what the MRI is showing, could be progression, could maybe not progression, could be maybe just treatment related. That's a big topic for us. Also, like as I mentioned earlier, we don't have an imaging marker to basically, that we can tell you, oh, the drug is getting in, it's responding. And so there's a strong need for the development of non-invasive biomarkers to assess the treatment response. And what we do know, and this is very common, and we knew this for a very long time, that tumor cells and also pediatric brain tumors have a very high concentration of this molecule, the enzyme called lactate dehydrogenase. And what it does is it converts basically pyruvate to lactate, so that in the tumor tissue, you have a really high concentration of lactate compared to normal tissue. And thus we now can exploit for imaging to have a better understanding if a patient is responding to therapy or not. And just to show you from an adult prostate cancer patient, this technology, which is using a lot of fancy technology to make this basically suitable for the clinic, but just on standard MRI imaging, this patient was diagnosed with unilateral prostate cancer. But when they applied this very specific, what we call hyperpolarized imaging, then they found that actually the patient had tumor on both sides, and that was biopsy proven. And now we can use that, And now we can use that also to look at response in our brain tumor patients. Sorry, I'm not sure why that's doing it. So for example, here in animal models, we now can see that already on day 1 or day 2, after the animal has been subjected to treatment, that we can see if the tumor is responding or not. And how great would it be if for our children, we have an early marker of assessment if a therapy is working or not, because then instead of waiting 2 months, going through all the side effects, we maybe be able to tell much earlier if there's a response or not. And so this is, again, something we are trying to develop. We are just starting to put this into the clinic for children as a really early phase study. But I think that's another very important space for us to watch to really improve sort of the outcome. So with that, I will conclude. I'm sure I'm way over time, but I wanted to thank you again. And obviously, this takes really a village, and these are all our collaborators. And again, a big thank you to the PBTF. Thank you.
Good morning. I want to thank the organizers of this meeting for this opportunity. It's really unique to get to speak to a crowd of parents of survivors, and it's an honor. I'm Stephanie Perkins. I'm an assistant professor at Washington University in St. Louis. I'm a pediatric radiation oncologist, and I take care of our children that require radiation at St. Louis Children's Hospital. So I wanted to start with a little background about my kind of thoughts about radiation oncology for our pediatric brain tumor patients. And you know, the good news is that with modern therapy, we are able to cure so many children with pediatric benign and malignant tumors. And what that means is that many of these children will go on to become what we call long-term survivors. And for some of these children, it's surgery alone or chemotherapy alone, but for many children, it's a combination of surgery, chemo, and radiation. And we're fortunate that over the last several decades, we've really made improvements in the delivery of radiation oncology, in which our number one goal, well, 2 goals, is to increase the cure rates for these children, but also to really focus on the long-term effects of our therapy and how we can improve those for our survivors. So I sat down and thought about what I consider my priorities as a pediatric radiation oncologist, and that's what I'll talk about today. So I think one of the big priorities for us as radiation oncologists is really identifying the best optimal treatment for patients. And for some patients, that's that they don't require radiation, that they're cured with chemotherapy and surgery. But for the patients that do require radiation, what's the best dose? Are we giving too much, too little? And what's the best volume? Do we need to treat the whole brain? Or can we do focused radiation? Can we do radiosurgery? And that's the way I approach each case, is what are the data that we have available and what's the best approach? And for those children that do require treatment, can we use modern technology? Of course we can. And what can we do with that technology? And what we want to do is design the most accurate and the most targeted radiation that we can. And that goal is always driven by our desire to decrease the long-term effects of therapy. And then lastly, what I'll focus on is, at the end of all of this technical stuff, what is the child experiencing during their time in our department, and how can we improve that experience? So first I'll start with that first priority, which is the optimal dose and volume. And I'll say that the way we've come across these data are because of parents like you who have enrolled children on clinical trials for us to learn. And we're always so humbled that our parents really, in the midst of this diagnosis, do put that as a high priority, that they want to contribute to the data for future children with brain tumors. And so for some tumors, like low-grade tumors, we know that surgery alone is probably fine, that these children will become long-term survivors, and that we don't need to administer any additional therapy. What about the dose? If we do know that radiation is important, think about medulloblastoma. 30 years ago, all children with medulloblastoma were treated the same, and they received high doses of craniospinal radiation. We now know that for some children, we're able to decrease that dose, and with future studies, molecular data, like Dr. Lin talked about, we may be able to omit radiation or further decrease the dose of radiation. But those answers are possible because of the clinical trials that our patients enroll on. For the patients that don't require craniospinal but can receive more targeted radiation, and even for our medulloblastoma that receive a boost, how can we best deliver that treatment? And we can think back to ependymoma, which was traditionally treated with craniospinal, and we now know that for patients with localized disease, that's not necessary, and that's a great advancement for our field. The timing of radiation is always important. Do we need to do it now? Should we wait? How old is the child? And those are all the conversations that we have around our round tables at our tumor boards. So once the decision is made to proceed with treatment, how do we do that, and what modern technology do we have? Well, this is what we had. Long before I was a radiation oncologist, we had x-rays. And we would literally draw the target on the skull and deliver that treatment. And that was about as much technology as we had. And as you can imagine, we were probably over-treating some areas or under-treating areas and treating normal brain that really wasn't part of the target. We still use CT scans. It's how we have to plan radiation. But with the advent of CT scan, we were able to really get a more three-dimensional picture of where is the normal brain, where is the tumor. And of course, MRI is now kind of our gold standard for determining, is all the tumor removed, is there any remaining? And so definitely over the decades, the improvements in imaging have really helped us as radiation oncologists improve our treatment delivery. And this is going to continue. There are so many new imaging technologies to help us track how nerves travel in the brain, where tumor might be, where it might not be. This issue that Dr. Mueller brought up, there's a change on the scan. What is it? Is it tumor? Is it not? And so this will continue to advance our field, both for our surgeons, for radiation oncologists, and medical oncologists. From a radiation standpoint, these images are really important for designing treatment. So here we have a child with a large cystic tumor. That child was taken to surgery, and if you watch, we'll see what the brain looked like as that child presented for radiation. So a big improvement from that initial tumor. But what about during the course of radiation? Is this the end of the story? And if you keep your eye on that surgical cavity during the course of radiation, the brain continued to heal, And these sorts of changes we need to know about for either it's bigger or smaller. We can change our fields to deliver more accurate treatment. Alternatively, this is a child with a cystic tumor, and during the course of radiation, we felt it was important to track that. And as you can see here, we saw increase in that cyst. This is when we might call our neurosurgeons or increase the size of our field. And so these images are really important in delivering that most accurate treatment. From a day-to-day basis for radiation, we want the patient to, I always tell the patient, you're setting up well. Well, what does that mean? That means that when they're on the table and they're getting their treatment, that they're aligned very accurately. And what that allows us to do is not introduce a lot of margin for error. And now we have what we call onboard imaging on the machines that allow us to really set patients up the most accurately that we can. What I wanted to focus on today also was the advancement of our technology with a focus on proton therapy. So proton therapy has been around for a while, but has not been widely available, probably more so in the last 10 years or so, and increasing in availability. And so most patients historically were treated with photon therapy or X-ray therapy. And the majority of children in the world and in the United States continue to be treated predominantly with X-ray therapy. I showed you that picture of the skull X-ray, and that's what we would have called a 2D technique, literally drawing the field and doing hand calculations of the dose. 3D conformal, sorry, that says proton, but it should say photon therapy, continues to be utilized for children receiving craniospinal with photon therapy, but is now computer-based and gives more accurate dose estimations. And many children are treated with IMRT, or intensity modulated radiation, which allows us to bend and shape the dose to areas that we want treatment and to areas that we don't. And then obviously proton therapy, which we'll talk about today. So let's just look at some comparisons. So here we have a child with a tumor. You can see the white tumor there on the right side of the brain on the screen. And what we want to do is to deliver radiation to that tumor with a margin, and that's drawn with the yellow line. In red is our target dose. That's the dose we want to give into the area that we want to give. And in green and blue are low doses of radiation delivered to areas of the brain we don't want radiation. There's no reason to do radiation to those areas, but with the technology, we're limited in our ability to decrease that dose. With IMRT, we can achieve even more conformality around the tumor, but again, having low doses of radiation that go to the opposite side of the brain. With proton therapy, we have more control over the exit of the beam. And what that allows us to do is really decrease the amount of normal brain that receives low doses of radiation. And I'll show you why. The reason this is important is obviously our goal to decrease the long-term side effects for our treatments. And, I think you guys are well aware of these issues. We know that our survivors have trouble with hearing as they get older, potentially trouble with vision, difficulty getting pregnant or having children on their own, decreased growth after treatment, hormone abnormalities, many of these related to surgery, chemotherapy, and obviously to radiation as well. And I think probably for parents, the two most concerning and what we probably have the longest conversations about are the last two, what are the neurocognitive or learning side effects of the radiation and the risk that the child may develop a second tumor as they get older. And our hope is that proton therapy will help with some or all of these side effects. What proton therapy is it's radiation delivered with protons. If you think back to your science class, this is the charged particle within the nucleus. Protons and X-rays behave very differently in tissue. X-rays have no mass, they have no charge. You can kind of think about they can travel very freely through tissue. Protons are heavy, they have charge, they interact with tissue, and that allows us to control how far they travel in the brain or in the arm, wherever we're treating. And so we can control the exit, and what does that look like? So let's pretend this red circle is a tumor. And in a perfect world, this is what our radiation plan would look like. Dose to the tumor, no dose anywhere else in the brain. In reality, with X-ray therapy, if we come in from the right, actually the left, you guys know it's backwards, right? So if we come in from the left and we point that beam, we deliver the radiation to the target, but as the X-rays exit, there is dose to the opposite side of the brain. It decreases with depth, but it's real. With proton therapy, it's different. So with X-rays, we see the dose kind of deposits, and then over depth, it decreases. This is for the science people in the room that like charts. With protons, we can say, let's deposit dose until 7 centimeters, and then we don't want dose beyond that depth. And what that allows us to do is get some dose distributions that we're happier with. So this is a child receiving craniospinal radiation. We come from the back to deliver the dose to the spine. And you can see for the child, for the dose on the right, there's exit of radiation through the anterior part of the body, through the heart and through the lungs, along that thin strip in front of the spine. With proton therapy, we can say, let's deposit the dose just in front of the spine, and no more, please, thank you. And really, there's no exit of radiation with that treatment. Similarly, this is a child that we treated, and on the left, you see the target dose of radiation, and that's how really a 3D conformal plan or an IMRT plan would appear if you just turned on the high dose. But with protons, when we lower that dose, let's look at 500 centigray, so the low dose of radiation, we don't see it going over into the opposite side of the brain. We don't see it going down into the temporal lobes or down into the neck, and that's what's unique about the physical properties of protons. This isn't a brain tumor, but this is a sarcoma in the sinuses. And again, just showing you that ability to control where the radiation is delivered. And so the last thing I wanted to focus on, because I'm sure we'll talk some more about protons in the question session, is, for the child, they're not really worried about that kind of stuff. They want to know what to expect, and this is a big priority in our department. We've taken a well child, someone that was in school 3 weeks ago, and now said, you're going to come to this machine every day for 33 treatments and lay absolutely still, and it's very scary. And so this is our proton unit in the department, and it's a little intimidating. What we have done through a very generous grant from the Barnes-Jewish Hospital Foundation is thought about ways that we could maybe help children that could get through these treatments without anesthesia. And we purchased this little Philips kitten scanner. So this is a mock CT scanner. And fortunately, we have a Philips CT scanner, so it looks just like this. And we have our child life specialists spend time with the children, usually when I'm speaking to the parents about some of the more difficult conversations, to run through what it's like to have an immobilization mask made. If you're not a Cardinals fan, it can be a problem because this is a St. Louis Cardinal teddy bear on the scanner. And he has an immobilization mask that our therapists have made. We have videos. Our child life specialist had a mask made so she can tell them what it smells like, what it feels like. And it gives the children a chance to take that bear home, show it to their siblings, kind of feel the mask and learn what to expect. And obviously for some of the children, they are too young to really even try without anesthesia, but we still run through that process with them if they're willing, and it gives them a chance to know what they're going through. And I do believe for some of our children has converted a child from requiring daily sedation to not needing it. And I think this highlights my last point, which has already been mentioned here, that we can't do this alone as physicians, and I think this importance of a need for a child life specialist in our department is well recognized, and we now have a full-time child life specialist available because she changes the whole feel of the department and the experience for the kids. Obviously, our radiation therapists are the technologists that deliver the treatment, and they play a huge role. One of my residents said, "Did you hear Joel was saying, okay, it's time for the ride. Keep your arms inside of the ride the whole time." You know, he's talking to the child throughout the treatment, and it's a huge deal. And I think it's great to know that departments are increasingly thinking about that. For our children that do need anesthesia, we have our anesthesia team from St. Louis Children's Hospital, and that's who the kids want to see when they come back for follow-up. They really get a great relationship with that team. And then our nurses, social workers, and all the physicians in the scenes and behind the scenes, with the goal of getting children through the treatment, you know, with a smile on their face, and that makes it all worth it. So I want to thank you all for your time and for this opportunity.
On behalf of the audience, I really want to thank all our panelists. We're all ears for every word you said, and we're now open to questions.
When you were talking about deimmunization therapy and just doing an injection, is that having a tough time going through that blood-brain barrier?
We don't know that. I mean, the idea is, so people, the classic teaching was for a long time that the brain is actually a very privileged place in terms of immune response. But with time, we learned that that's not true, that there's a lot of immune cells in your brain. But we don't know yet. But from the adult experience, I would say that there's definitely responses we see, and how to maximize that. Because the idea is you give a vaccine in the arm or the leg, like you give any vaccine, and then your immune system responds to that. And then the immune cells travel to the brain, and they can travel. So that's different in terms of drugs, which have to really actively cross the blood-brain barrier. So it's a different, but we don't know yet how effective it will be for our patient population.
What's your guess on how long it'll take before the catheters into the tumors in the brain become commonplace?
Oh, that's a very good question. It has taken a long time, and there had been a multi-site adult study using that technology. And I think for this technology, the devil is really in the detail. I mean, just placing a catheter is just not good enough. You need to have the experts, neurosurgeons, the imaging people, because what we found is in the early trials in adult patients, if you put a catheter in, but you use the wrong track, you use the wrong amount of pressure you put with your infusion pump, it just back leaks along the catheter, so it actually also doesn't reach the target. So there are a lot of details. So I think that is a technology which has to be carefully evaluated in single centers with the exact expertise, and then it has to be distributed to other sites. So it will be a few years, I think. But it's a very exciting area, I think, for our children.
I have a question. My son was diagnosed over 11 years ago, and unfortunately, there was no proton radiation accelerators anywhere near where we were living. Given the positive opportunities today, what do you tell families when their child does need radiation? Do you say 100% go to proton, or do you still defend the regular X-ray radiation?
It is, I knew when I came back to WashU, our proton center had not quite opened, and so we were still at that point sending patients out. And it is very difficult because there's not, for each family, the challenges that they're going through and the particular diagnosis all go into that decision. If we have a single mother with 5 children, the ability to travel has to be part of that conversation. So I don't know that there is a right or wrong answer. I think what's important is that the parents are informed, and so we fortunately have a proton therapy center now, so that conversation usually revolves around our plans for treatment. But for centers that don't, and there will continue to be many centers across the country that don't, they often will send the cases for us for review, so I think that that's a reasonable place to start. And, you know, the data behind proton therapy is just emerging. So we can't say this is wrong, you have to send. I mean, it's something that needs to be continued to study. And I think for many years that X-ray therapy will continue to be how the majority of children are treated in this country. And I think that that continues to be an appropriate recommendation for centers. I hope that answers the question.
Yeah, I mean, I think that's also a question I would have for Dr. Perkins, because first of all, I think as a neuro-oncologist, I mean, all our patients now are asking exactly that question. And in discussion with different radiation oncologists, I mean, first of all, we don't know yet if with proton beam therapy we get the same cure rates. I think we also don't know if there are other side effects because of the different doses these children might experience. And for some tumor types, and I would be really curious to hear your thoughts as well, we know that the tumor, the cells actually do migrate right outside the surgical field. So you actually want to have that area also covered. So I think for some of the locations, some of the tumor types, having actually that margin might not be such a bad thing. And I think we just don't know yet exactly in terms of tumor recurrence, are we achieving the same rates? And it might be really tumor type specific. But from our experience, so we normally discuss it with our radiation oncologist. If there's a strong rationale, for example, the most cases we refer then to a proton center is when the tumor is located very closely, for example, to your optic tracts. And if you would have that additional radiation beyond the tumor, you could really jeopardize the child's vision. Then these are cases, you know, where we strongly made an argument, if a family can do it, to go to a proton beam center. But I would agree that the data is still emergent, but.
Yeah, I think, you know, from a research standpoint, the two questions that we need to answer about proton therapy is, are the cure rates equivalent? And that data is a little easier to come by and is starting to come out, results from ependymoma and medulloblastoma treatments from MGH, which has been around the longest. The second question that is harder to answer and takes many years is this technology improving the late effects for children? And, you know, hearing and neurocognition are probably those we can answer first, although we all know getting those tests and things are challenging. But the effects on the blood flow of the brain, the effects on secondary malignancy will take decades and requires the children to continue to come back for follow-up. And so it is a big challenge, but it's very important to justify this therapy.
I agree. Do I not? Okay. Thank you. I agree completely with the last several comments. And if I would just throw out one additional comment, for me, it's definitely that data as it emerges really does help on a case-to-case basis how we make these decisions. But a logistical challenge I've discovered over in the last year or so, it just seems to be more and more of an issue, is just the additional conversations with insurance companies having proton covered. And we do have access to a proton machine in Houston, but as we make referrals for radiation therapy, whether it's photon versus proton, it's been a more frequent conversation, at least anecdotally it feels like, to try to back it up and justify it with what data that's currently available. And as we've heard, it's something that's really emerging, and we're definitely at a place where we're learning a lot about it, but it hasn't quite made it to some of the more kind of practical and logistical issues that we're trying to also do to advocate for each child.
Hello? Yeah, hi, Dr. Perkins, thank you so much. So my daughter was diagnosed with a optic chiasmic glioma, and we had proton therapy, probably, well, it'll be 5 years this March. And one of the side effects that you had not listed, of which is my question, is she has, I would classify as chronic fatigue. You know, the level of fatigue where you don't have energy unless you have medication to give you energy, right? And so I just noticed it wasn't on your list and wanted to hear your comment on that. Thank you.
Yeah, thank you for the comment. You know, I think with all of the advancements that we've made, there are still so many issues that we don't understand. One of those, kind of along your lines, is somnolence syndrome. This is something that happens occasionally after children receive radiation, and we have no idea. I mean, I don't. I'm sure there are others that are doing research. And, you know, for most children, it's self-limiting and resolves, but there are so many processes that are going on. And, you know, the pictures for what we do in some ways may look better, but it is so important to make sure that we're not missing other issues that could emerge. And so I think what we have done is we've really tried to enroll all of our patients on a study to start to collect these quality of life and long-term issues, because there can be some unknowns. And there are lots of other issues that weren't on the slide that, you know, we continue to put on the top of our list in our survivorship clinic.
This is for Dr. Mueller. I have a daughter who's 15 years old with an optic way glioma, JPA actually, and she's participating in the PNOC study through University of Utah, has a BRAF inhibitor. After we had the frozen samples and the molecular study conducted, she was right away prescribed with everolimus. So I guess that's more of a melanoma drug. So what category does that fall into, whether that's immunotherapy? I thought it was more of a virus-driven, but I don't understand why a melanoma drug after a frozen sample section has been reviewed is being prescribed.
Mm-hmm. So I think that there are two studies, and I want to make sure I have it correct. So it seems that your child is receiving everolimus, right? And so everolimus is a medication which we know it's not a viral therapy, it's not an immunotherapy, it's a medication we know blocks one of the pathways. So all these different tumor types have sort of what we call signaling pathways, which basically stimulates the cell to growth. So these are sort of growth signaling pathways. And everolimus blocks one specific aspect, and we have seen in many, many animal models that the pathways which are activated specifically in these low-grade astrocytomas, just as the optic pathway gliomas or pilocytic astrocytomas, whatever, sort of the same thing with different names, that this pathway is very important. And so what the study is trying to do is look if everolimus is efficacious. And we know this actually from other studies that it is specifically in low-grade gliomas. But what the difference about this study is we are trying to look in the tumor tissue to see if we can identify a biomarker which would help us to tell families early on, because you have that biomarker, you are more likely, your child is more likely to respond to the therapy. And this is what we tested in the tumor, and that marker is called, just to give you the name, phosphor-S6. It's sort of one of these molecules in that pathway, and we know that everolimus acts on that. The other medication I think you're referring to is actually what was shown also earlier, is vemurafenib, and that acts against a very specific mutation, which is shared with adult patients with melanoma, but we also find this mutation now in a subset of pediatric gliomas. There's all different kinds. And for these low-grade gliomas, it's about 10% of these tumors have that mutation as well. And I mean, the common theme is really like, right, we have to lean on the adult development so that we can bring it to pediatrics, because that's unfortunately still the reality we are facing. And so we are lucky in a way that we share that with the melanoma patients, because a lot of companies are very interested in using that and developing agents for this, because it's a big market, you know, it's profitable for them. And then we can borrow that expertise for our pediatric patients. But two different mutations with two different agents. But if I would classify it as a therapy, I would say it's one of these more targeted therapies, but it's not immunotherapy, yeah.
Hi, my name is Karen, and I have a son who was diagnosed with an astrocytoma glioma almost 5 years ago in the brainstem, so it's inoperable. But my question is for Dr. Lin about that genomics. I have no idea if they ever did that on him, you know, to see. Is that something new, or is that a standard thing that hospitals and doctors do, you know, the surgeons?
Right. I think as far as a standard, it's something that I think most of us are suspicious will become one. A lot of institutions, the neuropathologists will already do, in a sense, they're molecular pathologists. They'll already do certain genes. They'll look for certain gene mutations already. Like our institution for low-grade gliomas, they'll look at a couple, like BRAF, as we just mentioned, and a few others. And these very specific genes that are altered, that's not something that's exceptionally new. For high-grade gliomas, certain things like MGMT or EGFR often gets looked at, and the question becomes, how do we use that information to benefit our patients? Something that's more broad, that covers much more of the DNA, the actual blueprint of each cell, each tumor cell, and every single person, that's something that's definitely growing and something that we're just learning to do. So five years ago, I think it's very unlikely that like an entire genome or entire exome, all these fancy terms for all the DNA or all the DNA that makes proteins, I think it's unlikely that that was done 5 years ago, and we're only learning how that's going to be useful for us going forward. But I think a lot of us are suspicious that, one, as the technology starts to make it easier and much more, one, financially more available, and two, from a time standpoint, much more available for us to make clinical decisions on it, that it's a technology that's going to be used more and more as a standard. And a lot of these clinical trials that we're now doing to try to figure out how we can target medicines, just like the vemurafenib or even everolimus for mTOR inhibition, this technology may be able to help us do that in a much more rapid fashion.
Okay, so is this something that we should be asking our oncologists and neurologists to look into? Like Daniel has an appointment coming up. Is this something I should be asking them to do? And is it through a tissue or a blood?
Right.
Labs.
Right. Yeah, so I'm clearly a little biased because this is the area that I'm very interested in. I think the answer to that is again, there's no real right or wrong answer, just my personal opinion. In one part, I would highlight there are a lot of commercial labs that are doing sequencing, and the results that come back are often very confusing. We just don't know exactly what to do with that information. And the practical issue is there's two aspects. There's one, we do the sequencing or the molecular analysis on the tumor tissue, and there's an ongoing debate as to whether the blood or a person's normal DNA should be done. Most of us in the pediatric side do think that there is benefit at looking at the blood, one, because it can compare we use that as a reference to compare what can be wrong or what can be altered in the tumor's DNA. A lot of commercial labs just look at the tumor itself. But number two, when the results are available, there are a lot of incidental findings that we're just now learning how to give to the patients and their families. So both families and physicians are really learning how to use that information. My personal bias is that yes, there's information that can be helpful for us, especially as new drugs are being discovered and being used and tested in early phase and later phase trials for children. And 5 years, it's whether or not your child's hospital has that tissue available to be sent and sequenced. It's not. I don't think it's the sort of information that's going to make clinical decisions. At least right now, it's not going to be information that you're going to use at the next visit or even a visit after. But it does become information that if there's ever tumors or cancers that return, may conceivably be helpful. And this is definitely a rolling target. Like, we're going to get better at targeting each of these changes in DNA. And the changes in DNA, we're going to get better at using that to classify and molecularly and pathologically identify what type of tumor it is. So, I think that was a long explanation for saying, I don't think necessarily there's a right or wrong answer. I do think we're going to keep getting better at it. And if not now and in the future, it's something I think it's worthwhile to keep in the back of your mind, because we will get better at it and it will become clinically more useful.
But quick question. So did your child underwent already tissue collection, or did you not have a biopsy?
Yes, they did a biopsy and tissue collection all at the same time. And I was going to bring this up, is like, it's been 5 years, and his tumor hasn't grown and it hasn't shrunk.
Yes.
We did chemo for a year and it didn't shrink, and our oncologist doesn't want to do the radiation because of the location and because the brain is so sensitive at such a young age, and
So I think my recommendation would be, as long as the tumor is stable and you wouldn't want to start therapy, I would not do this now, because technology is developing, as we are hearing. I would save that tissue, and then if you hit at one point, and hopefully you will never have to start therapy, hopefully the tumor remains stable, and that we often see that in less location if it's a low-grade tumor. I would do it at time of, when you really need to make a therapy decision.
okay.
And I would wait for this, because you don't know what will come out in the next few years. We learned a lot about the underlying biology of these low-grade astrocytomas, but I would save the tissue until you really need it. I don't see any reason to do that right now.
Okay, thank you.
And at recurrence, sometimes we talk about a rebiopsy because maybe the tumor has changed. So that's another question that would want to be on the table.
Okay,
Yeah.
thank you.
I just have a question. My son is 17 years out from medullo, and he was just diagnosed with a silent lacunar infarct. And what is the mechanism that causes that, and what is the incidence of recurrence?
Mm-hmm. So Dr. Perkins and I, we are actually part of a study, or we initiated a study looking specifically at the long-term vascular side effects of children who underwent radiation therapy. So we looked at this because we know that children who received radiation therapy in the past are at higher risk for stroke. And we think what we know from the adult literature, and when we can look more at tissue, when head and neck cancer patients, for example, get radiation to that area, we know that these vessels get stenosis, they change, they become narrow so that the blood flow isn't the same, and the surface becomes altered so that you basically get these strokes. And we think this is a sort of a more old person disease, right? So we don't really, and I think the mechanism of difference. But what we think is going on, so there are two mechanisms. One is it can cause a change, radiation can cause a change to the vessels in the brain, making them more narrow, and that can cause stroke. We also know that it can accelerate atherosclerosis. And atherosclerosis is sort of a common mechanism for adult strokes, but we know that our pediatric cancer survivors, there are several studies out now, especially in collaboration with the childhood cancer survivor studies, that there's premature aging in our survivors ongoing because of all the therapy they received. And so what we learned by looking at some of the data, and these were patients, so you need to take this a little bit with a grain of salt, that data, but these were patients treated in the 70s. And when we looked at them who had strokes, we identified that atherosclerotic risk factors, which normally don't play a role in strokes in children, do play a role in pediatric cancer survivors, specifically if they received radiation therapy. So what we are doing at UCSF and now at a few other centers, we are actually checking regularly, cholesterol panel, markers for hemoglobin A1C, and then we actually collaborate with our lipid experts, with our vascular expert, and we have now several patients actually on these aspirin, Plavix, classic sort of more adult stroke therapy. But we are starting to investigate this more and more. But I think the underlying mechanism, most likely for lacunar stroke, is really maybe accelerated atherosclerosis, the best we can tell. And there's no great imaging for that. But you could, I don't know if all these other things were checked, but that would be potentially an advice.
I'd like to thank everyone again. Thank you very much.